Hello everyone. In today's session, we'll be learning about the inguinal canal anatomy, a very important topic as far as your theory exams are concerned. Okay, many a times long questions are asked on this topic and many case-based questions also you can expect from this topic. Okay, so let's begin the topic. So just like for other topics, we have made notes. So here we can see a concise notes for the inguinal canal topic as well. So where is the inguinal canal located? It is an oblique intermuscular passage in the lower part of the anterior abdominal wall. It lies above and parallel to the medial half of the inguinal ligament. Okay, as we can see in this image, this is the region of pubic symphysis, this is the pubic tubercle, and that's the anterior superior iliac spine. And the green color thing that we can see, that's the inguinal ligament. So it is superior to the medial half of the inguinal ligament. Okay, and length is about 4 centimeters. It extends from the deep inguinal ring to the superficial inguinal ring. Okay, there are two rings which are there. This one is the superficial inguinal ring above this pubis, and this one is the deep inguinal ring. Okay, so how are these rings formed? Let's understand them. Superficial inguinal ring, it is a triangular gap in the external oblique aponeurosis. It lies above and lateral to the pubic tubercle. Okay, so there is a muscle called as external oblique. Its aponeurosis has an opening called as superficial inguinal ring. Okay, the pubic crest forms the base of the triangle, and the medial and lateral margins of the triangle are called crura. So it is a triangular opening which has got a base and the side margins. Okay, the two crura are united by the intercrural fibers. Some intercrural fibers are there between the two margins. Okay, then deep inguinal ring, it is an oval opening which is seen in fascia transversalis. It lies about 1.25 centimeters above the mid-inguinal point. Okay, where is the mid-inguinal point? Here, this point. Okay, mid-inguinal point is the midpoint of pubic symphysis and the anterior superior iliac spine. Okay, 1.25 centimeters above it is the deep inguinal ring, and it is an opening in fascia transversalis. Okay, the inferior epigastric vessels are present just medial to it. Okay, so in this region, the inferior epigastric vessels would be there. Then there are multiple boundaries of the inguinal canal. Let's see them. So boundaries are anterior wall, posterior wall, roof, and floor. Okay, anterior wall includes the skin, superficial fascia, the external oblique aponeurosis in its whole extent, as well as internal oblique muscle fibers in the lateral one third. Okay, then posterior wall of the inguinal canal, it is formed by fascia transversalis in its whole extent, and there is conjoint tendon in the medial two-thirds part, and there is reflected part of the inguinal ligament in the medialmost part. Okay, so to understand this, we can see how the internal oblique muscle fibers are there here. It arches over and it goes on the posterior aspect as well. Okay, so that is why posterior wall we can see this conjoint tendon. Conjoint tendon, it is formed by the fusion of internal oblique as well as transversus abdominis. Okay, and roof is the arched fibers of the internal oblique as well as transversus abdominis muscle. Floor is formed by the grooved upper surface of the inguinal ligament in its whole extent as well as lacunar ligament in its medial end. Okay, so this is the region of floor, the external oblique aponeurosis which is there. It upturns at this level and it forms the floor of inguinal canal. Okay, these were the boundaries of the inguinal canal. And contents of the inguinal canal: in male, it has spermatic cord and ilioinguinal nerve, and in females, there is round ligament of uterus and the ilioinguinal nerve. Okay, there are further contents inside the spermatic cord that we'll be seeing in some time. Okay, and there are multiple factors which help in maintaining this inguinal canal in its proper position such that herniation doesn't take place. Those are referred to as inguinal mechanisms. Okay, it maintains the integrity of the inguinal canal. So which are they? One mechanism is called as flap wall mechanism, in which the deep and the superficial inguinal rings, they do not lie opposite to each other. Okay, deep ring is this side, superficial ring is this side. Whenever there is a pressure increase, then both rings are not at same level, so contents from the abdomen may not come out. Okay, this is called as flap wall mechanism. When the intra-abdominal pressure is raised, anterior and the posterior walls of the canal are approximated like a flap. Okay, And there is ball valve mechanism of cremaster muscle. Okay, the contraction of the cremaster muscle pulls the testis up, and the superficial inguinal ring is plugged by the spermatic cord. Okay, this is referred to as ball valve mechanism. And shutter mechanism, in which the internal oblique muscle fibers, it is present in the anterior wall, it is present in the roof as well as the posterior wall. Okay, as we can see here, the internal oblique muscle fibers, anterior wall, roof as well as the posterior wall. Okay, when this muscle contracts, the roof is pulled and approximated to the floor like a shutter, so that prevents herniation. Okay, so that is called as shutter mechanism. Then there is slit valve mechanism, in which there is contraction of the external oblique muscle approximates the two crura, the medial and the lateral crura, which are there here. Approximation of this occurs when the external oblique muscle contracts. This is referred to as slit valve mechanism. Okay. Then there are some guardings of the inguinal ring. Okay, deep inguinal ring is guarded anteriorly by the internal oblique muscle fibers, and superficial inguinal ring is guarded posteriorly by the conjoint tendon. Okay, as we can see here, there is a superficial inguinal ring. Posteriorly, there is the conjoint tendon. Okay, and this is the deep inguinal ring. Anteriorly, there is the internal oblique muscle fibers. Okay, so this schematic diagram you can draw for the inguinal mechanisms. So this was about the basic boundaries, contents, and the inguinal mechanisms. And roof and floor, we can see in this image as well. Roof is formed by internal oblique transversus abdominis. Floor is formed by the upturned portion of the inguinal ligament. Okay. So whenever you're writing the answer, make sure you draw some schematic diagrams to assist whatever you have written. Okay. Then spermatic cord, I told you, it further has got many contents. Okay. So the spermatic cord extends from the deep ring to the posterior border of the testis, which is present inside the scrotum. There are many coverings of the spermatic cord from outside to inside. It is external spermatic fascia, cremasteric fascia, and internal spermatic fascia. Okay. And they are derived from one or the other structures from the anterior abdominal wall that is mentioned here. The external spermatic fascia is derived from external oblique aponeurosis. Cremasteric fascia is derived from internal oblique as well as transversus abdominis aponeurosis. Internal spermatic fascia is derived from fascia transversalis. Then contents of the spermatic cord. Okay, there are multiple contents which are shown in this diagram. Okay, the chief content that we can see, that's the ductus deferens, a thick cord-like structure would be felt here, and there are many nerves and vessels. Okay, all of them are labeled accordingly and mentioned in this table. You all can go through it. Okay. Then there is a triangle called as Hasselbeck's triangle. So where is it located? It is located bilaterally in the lower anterior abdominal wall above the groin. Okay. So this is the region of the inguinal canal. Above it, we can see one triangle here. That's the Hasselbeck's triangle. Okay, it is important for differentiating the two different kinds of hernia. Okay, let's understand the boundaries of it. Medially, it is bounded by the lower part of rectus abdominis muscle. Laterally, it is bounded by inferior epigastric artery. Okay, basically the inferior epigastric vessels are there, that is present in the lateral boundary. Inferiorly, there is the medial half of the inguinal ligament. And floor is formed by the peritoneum, extraperitoneal tissue, and the fascia transversalis. Floor means the posterior part here. Okay. And this Hasselbeck's triangle is further subdivided into two triangles by a vessel which is present here, called as obliterated umbilical artery. Okay. There is an obliterated umbilical artery, which is also referred to as medial umbilical ligament, crosses the triangle and divides it into medial and the lateral parts. The medial part of the floor of the triangle is strengthened by conjoint tendon. Okay, the lateral part of the triangle is weak, and hence direct inguinal hernia usually occurs through this part. Okay, when the herniation occurs in Hasselbeck's triangle, it is referred to as direct inguinal hernia, and here also the lateral part is more vulnerable to hernia because the medial part is strengthened by the conjoint tendon. Okay, conjoint tendon, we saw it is the internal oblique muscle fibers arched and it formed the conjoint tendon in the medial part. Okay, so the medial part is strong. Okay, so this is the direct inguinal hernia which occurs from the Hasselbeck's triangle. Then inguinal hernia, let's learn in details. Okay, what is the inguinal hernia? It is a protrusion of abdominal viscera, usually a loop of intestine or a part of omentum, into the inguinal canal. Okay, there are two types of inguinal hernia: direct inguinal hernia and indirect inguinal hernia. Okay, understand the basic parts of the hernia from this. Okay, there is a neck of the hernia, there is a content which is usually a loop of the intestine, there is a sac of hernia, and there are multiple coverings of the hernia. Okay, then what is a direct inguinal hernia? We just learned when the hernial sac enters the inguinal canal by pushing the posterior wall of the inguinal canal through the Hasselbalch's triangle. Okay, and we learned this triangle is divided into two parts, medial and the lateral part, by this obliterated umbilical artery. Okay, so that's why there are two different subtypes of the direct inguinal hernia called as lateral direct inguinal hernia and medial direct inguinal hernia. Okay, the neck of the hernial sac is wide in this case, and direct inguinal hernias are common in elderly due to the weak abdominal muscles. Then what is an indirect inguinal hernia? Let's see, when the hernial sac enters the deep inguinal ring, then to the inguinal canal, and then to the superficial inguinal ring into the scrotum, this kind of hernia is referred to as indirect inguinal hernia. Okay, and this herniation starts lateral to the inferior epigastric artery. Okay, it is common in children, young adults, and it can be congenital or acquired. Okay, congenital indirect inguinal hernia means there is a processus vaginalis which extends from the abdominal wall towards the scrotum. Okay, if there is a persistent processus vaginalis, the herniation can occur through that. Okay, then acquired indirect inguinal hernia due to increased intra-abdominal pressure during weightlifting. Okay, so in that case, the herniation can occur from the deep inguinal ring to the inguinal canal, and then it comes to the superficial inguinal ring. Okay, this kind of inguinal hernia is indirect inguinal hernia. Okay, clinical differences between the two inguinal hernia are mentioned here. Age group: indirect inguinal hernia is common in children and young adults. Direct is common in elderly. Okay, then etiology: there is a preformed sac which is present here, and here is the weakness of posterior wall of the inguinal canal. Okay, precipitating factors for direct inguinal hernia are chronic bronchitis, enlarged prostate, usually in old age. Okay, on standing, the indirect inguinal hernia doesn't come out. Direct inguinal hernia can come out. Direction of the sac is directed downwards, forwards, and medially. And this direct inguinal hernia is directed forwards. Obstruction of the inguinal hernia is common in indirect inguinal hernia. Okay, in direct inguinal hernia, it is not common as the neck is wide. Then there is a test called as internal ring occlusion test, which is negative in indirect inguinal hernia, positive in direct inguinal hernia. Extent: it goes towards the scrotum. Okay, indirect inguinal hernia, direct inguinal hernia is rarely scrotal. Reducibility means we can push the hernia back. Okay, sometimes it is irreducible, and direct inguinal hernia is always reducible. Okay, and there are multiple coverings of these inguinal hernia that are mentioned in these diagrams. Okay, coverings of indirect inguinal hernia, coverings of lateral direct hernia, coverings of medial direct inguinal hernia. Okay, for that you can just practice these diagrams and understand different coverings. As we can see, coverings of indirect inguinal hernia. Indirect inguinal hernia was coming from the deep inguinal ring. Okay, so it is covered by the peritoneum, the extraperitoneal tissue, internal spermatic fascia, cremastric fascia, external spermatic fascia, skin. Okay, then coverings of lateral direct inguinal hernia. We can see from outside to inside there would be skin, the external spermatic fascia, the cremasteric fascia, the fascia transversalis. Okay, then the parietal peritoneum and the herniated loop of intestine. Okay, difference between this indirect and the lateral direct, you can see here is the internal spermatic fascia and here is the fascia transversalis. That is one difference, otherwise the coverings are common. Okay, and if you see the medial direct inguinal hernia, there is one covering which is distinct here, that's the conjoint tendon. Okay, conjoint tendon is basically formed by the fusion of the internal oblique and transversus abdominis. So here we can see this external spermatic fascia is there, but cremastric fascia is not there. Okay, instead of cremastric fascia, this conjoint tendon is here. Okay, There would be some specific covering in different types of the inguinal hernia. So for that, you all can just draw this diagram and label it properly. That would be sufficient. Okay. So this was all about the inguinal canal along with the contents of the spermatic cord, the Hasselbeck's triangle, and the inguinal hernia. Okay. Notes of this topic, you all can just scan this QR code and get it. Okay. And many other notes we are continuously making. Keep visiting this store. You'll definitely get good content. Okay. Thank you.